Welcome to the MK Excellence Coaching Program, and today's topic, PED deployment strategies. Now, this is something that has developed and evolved over the past 5-6 years. So this is definitely a topic that I want to cover in great detail. And if there's any questions or anything that anybody needs to address specifically, we can get stuck into that another time. Now, PED deployment and usage, as well as how we look at drugs, has definitely evolved and changed over the past years. Now, we've got a lot more research that has come through, which to a degree is applicable. However, the anecdotal evidence that we actually have now is also far, far greater, with a lot more people being a lot more open about the use and what they do and how they do it, which I do believe has had a massive positive influence on being a little bit smarter with the use, compound design, and more importantly, compound selection. Now, the main changes and advancements we've seen so far, stack design being based around drugs that are approved for human use. The outline of the drugs that are approved for human use, I will go over in a little bit. Now, total milligram dosages for individuals being based off the specific needs and goals. Back in the day, people always used to have just arbitrary numbers thrown around that this is what you have to take to achieve set goal. That is simply not the case. The total milligrams that you need to take will be based off your needs, but will also be based off your development, your training age, and your previous use, and even size to a degree. It should not be just an arbitrary number that has been used previously in past years, where no matter how big your athlete was or how little your athlete was for that matter, it would be the same amount used. Now, understanding of how each compound works and why it should be used in the industry, I think that's a huge one, especially amongst female use. We now have a larger understanding of what females can and cannot tolerate that well. And this is where I will definitely throw a little bit of a spanner in the works where, a lot of educators are of an opinion that, for example, Primo is safer, or I would say causes less fertilization than Anavar, which in reality, in practical evidence, in anecdotal evidence, in real life case scenarios, that is simply not what we see on a milligram to milligram basis. And this is for various reasons. I do believe one is simply stronger than the other. And generally, if we do have a compound that, milligram for milligram is going to be stronger, it will also lead to a little bit more side effects in itself. Now, Trenbolone, specific dosing, uses, and effectiveness, that's a huge one. Back in the day, we have always had extremely high Trenbolone use, and I do believe that shift has been the right one and probably the most effective and the most logic out of the main change that we have seen over the years, especially around Trenbolone use, which I will get stuck into in a little bit as well. Now, estrogen management via stack design and not using aromatase inhibitors. This is me not saying that aromatase inhibitors should never ever be used. This is me simply saying there is a better way to manage your estrogen levels, and estrogen should not be demonized. Now, further along, when we look at assessing blood work and when we look at just general blood work in place, another thing that most people overlook is that certain compounds will actually show up as estrogen in your blood work unless you actually have a specific test done that is a lot more expensive, a little bit more extensive as well. Trenbolone and nandrolones will always show up on your blood work as estrogen. So if you do have a client's blood work come through and estrogen is very high and they are using Trenbolone or nandrolone for that matter, that might give you the answer as to why it's high. This is where it would be a lot more logic to actually go off the feedback your client is giving you and the visuals to see if the estrogen is higher or not, as that is pretty easy to pinpoint as well. Now, phase-specific compound use, dosages, cycle design, or reuse, TRT, cruises, and off-cycle periods, they're all phase-specific. So they will vary depending on individuals and depending where you are in your timeline. So your compound and PED design, PED deployment has to be phase specific. It's extremely important that you set your timelines, set your goals, and design your actual cycles around specific time periods and time frames. PED cycle periodization, again, a huge one. We cannot stay on forever. Even if someone's blood work is great, I still think we need periods of downtime and periods of actually utilizing less drugs for various reasons. Oxidative stress, and I do believe that plays a huge role on your insulin sensitivity, and also mentally and physically, your body simply needs a break from a higher drug load in order to be able to get more from less next time around and actually see a little bit more progress occur as well, because I have seen a lot of people come to a little bit of a standstill in progression simply through permabulking and staying on constantly. So PED cycle periodization is huge amongst males and females. I mean, any female who wants to stay feminine and is looking to uphold the ability to actually keep, I wouldn't say just female hormones in check, but also ability to actually have a child in the future, this is where you need to have periodization in place, and it needs to be specific. And to a degree, there's a trade-off where your goals versus reward ratio needs to be considered and where you are actually at that moment in time. So compound use affects anecdotal evidence-based indicators as well. Mastron, I think it's very, very, very handy to actually go over each compound that is generally the most, I would say, the most popular and compounds we should actually all be using. And I would like to go over some things that I have seen myself through anecdotal evidence and through research-based factual stuff that has been seen under medical supervision to a degree. So we'll start with Mastron, right? Its potential to inhibit prolactin is extremely high. This is why Mastron works extremely well paired with Trenbolone. Primobolan doesn't actually have that effect, and I will get stuck into Primobolan a little bit more. Now, Mastron allows for estrogen side effects modulation and elevation androgen to estrogen ratio. So all this means, guys, is we are taking more androgens that do not aromatize, and that in turn creates a less estrogenic environment within your cycle. Because Mastron is not anti-estrogenic. I don't believe that, Mastron works as an AI. It does allow you to tolerate more testosterone when it is paired with it through elevating androgens, but it does have very little to no effect on actual estrogen levels. And that is something I've seen myself and many, many clients. One interesting fact I have seen with Mastron when it comes to my lipid profiles and when it comes to a lot of clients, and again, there is outliers in this because I have seen clients that solely use Mastron and it works in a different fashion. So what I'm saying here, guys, is applicable in most cases, as is any drug use. So always be mindful of that, guys. This is why I'm always extremely skeptical of any studies that come out, because how drugs work on a larger scale will be similar across the board, but there is always outliers, and always be aware of that. Comparing Mastron to Primo, it does not crush HDL. This is why my preference for off periods, cruisers with large individuals that do require a higher milligram dosage to hold the muscle mass, my preference is always utilizing Mastron for that reason, because the lipid profile recovers much quicker and it does not have such a harsh effect on HDL as opposed to Primobolan, which does. Now, Primobolan, and this moves perfectly into it, because Primobolan does lower actively estrogen a lot more. And I do believe that is the reason why Primobolan also lowers HDL much, much more in comparison to Mastron. So this is the main difference between both, in my opinion. Now, Primo, I do believe, is a little bit stronger when it comes to more so the anabolic effects. Mastron is great when it comes to neurological drive, in training performance. So this is why, personally, in a push-up phase or a contest prep, I do like a mixture of both for the properties that both have indeed, which is, again, with Mastron, inhibiting prolactin, especially in contest prep when using Trenbolone, and with Primobolan, lowering estrogen much, much more than Mastron, but there's always a trade-off. It does result in being a lot harsher on the lipids through lowering HDL dramatically. This is where you need to pay attention to clients' lipid profiles and making sure that you are taking care of the actual cholesterol as a whole. Now, on a milligram to milligram basis, in comparison to Mastron, I personally do get a lot more from Primobolan. However, getting more out of that drug also means a little bit more of a harsher effect on lipid profile, and that's something that I am willing to accept as a trade-off with my risk to reward ratio with where I'm at. Now, Primobolan, much more anabolic. I do believe that it does give a little bit more fullness in terms of the visual aspect as well. So I do believe it is a little bit of a stronger compound, but again, not in all cases. Some guys simply get on much better with Mastron. This is where trial and error needs to happen with your clients on an individual basis. You need to try different methods when it comes to PED, cycle deployment, and different stack designs to see which will have a better effect on yourself or your clients. Now, moving on to Trembolone. And this is a fun one because it's actually much less anabolic than testosterone, on a contrary basis to old research. I mean, there's still guys that are adamant that Trembolone is the most anabolic and the strongest drug out of them all, and it simply isn't. Trembolone has a very unique purpose, and its binding affinity to the androgen receptor is much, much greater, and to a degree, its muscle sparing effects are much, much greater than any other compound. When you actually look at Trembolone, especially used in higher doses, it does not give you any more, and it's not more potent than Mastron or Primobolan or testosterone by any means. If anything, Trembolone at a higher dose will have such large effects on your sleep and appetite, making an environment that is not going to be the best when it comes to either losing body fat or trying to gain muscle tissue. So with Trembolone, lower doses do prove to be a lot more effective. Higher doses contribute to a lot more inflammation and in turn, less progress. So the devil is not in the compound. The devil is simply in the dose that you are using with Trembolone. So my advice is starting as little as 50 milligrams, and I don't believe anyone or many people would need anything above 250 milligrams maximum, and that would be for someone that is competing on stage at around 250, 260 pounds lean. So again, you have to take consideration someone's size, body weight, in the lean muscular mass, in my opinion, when it comes to stack design and how much of the compound they may need. And again, outliers, some people may need more, some people may need less. And some people can actually get on much better without Trembolone use because of the side effects it will have on sleep and cognitive function. And in some people, anxiety can go so high, it just is not worth using even at smaller doses. Now, some fun facts about Trembolone and its clinical use. It was actually used under medical supervision, and it was used at a dose of 76 milligram per week. And generally, the pharmaceutical Trembolone was Parabolan, which is Tren-Hex. Some of you will have been very similar, and well, you've probably heard the Parabolan phrase used around a lot more, with people saying it's the strongest Trembolone. It actually isn't, because out of that 76 milligram, you only get around 50 milligrams of Trembolone out of that 76 that is bioavailable, which means that people was only using 50 milligrams per week. And that was used between 7 to 10 days basis. So as you can imagine, when we look at compound use, we try and keep it within the realms of how it was used clinically, right? So Trembolone, no real adverse side effects, and it was used clinically with humans at such a low dose. So it does make sense for us to be able to use a similar dose, obviously within means of what we need. That means it will probably be escalated slightly. However, you know, using 100 milligrams of Trembolone per week, that is using double the amount of Trembolone of what it would be used clinically. So you have to consider that as well. Now, SARMs, tissue selective compounds, greater anabolic potential than test, but less androgenic than tren. And that's anavar, winstrol, mastrol, and nandrolone. Non-steroidal SARMs, for example, ostrine, cardarine, very, very popular, special ostrine in female use, cardarine used for more so recovery of HDL. However, cardarine has not really been approved for human use. So there is better compounds you can take that do promote heart health, such as telmisartan, which has been used and has been shown to actually promote much better lipid profile and improvements in HDL as well. So there's better options than using non-steroidal SARMs that have very little research as well. Now, steroidal SARMs such as trenbolone, obviously been used for decades with medical supervision and no adverse side effects have been documented at the dosages that have been prescribed by doctors. Now, let's talk about estrogen. And this is a hormone that has been extremely demonized amongst many, many people for many, many years. Now, somewhat recently, we have seen a little bit of a U-turn on estrogen. And this is where I want you to all understand that there has to be a happy medium. I do not agree with a lot of educators claiming that you should run your estrogen as high as possible. That is just simply not the case. You should just run your estrogen as high as you can physically handle with no adverse side effects. Now, if you are getting bloated and you are having excess water retention, any potential sign of gynecomastia, or even potential erectile dysfunction, it does not make sense for you to continue driving up your estrogen higher and higher because it's not going to make you feel good. Now, estrogen does have some actual anabolic properties, so it cannot be crushed to an absolute bottom. Estrogen does show some actual protective measures when it comes to your renal health, your heart health, and your brain health. So it does make sense to keep your estrogen, when possible, especially for the majority of the year, in a healthy state. Now, a healthy state may mean within range or slightly above range. It all depends on the feedback that we get from a client and the feedback that we get from our own bodies to see exactly where you would sit at most comfortably. So extremely important with anabolic use. Using OI or as little as possible is key for successful off-season because our goal going for an off-season is to also keep the athlete or keep ourselves as healthy as possible, which means that the healthier we are, the more progress we can make. And in turn, if you are healthy, the likelihood of you cutting your cycle short is not going to be there. However, if you're using a ton of AIs on top of your drugs you're already taking, your stack design, that may actually mean that your runway for progression is going to be cut short simply down to poor lipid health. So why should we avoid using AIs? Your stack design should be absolutely perfect and should be designed to actually control your estrogen. So there is no real use for any AIs in 99% of the time because your stack design should be covering you from that basis by use of mastrolone and primobolan as your main driving compounds for hypertrophy. So AIs can be great for situational use, and it should definitely not be a permanent tool as more so a preventive measure. So in an instance where I think AI use would be sensible to use, if someone has the blood work done and the estrogen is sky high, they've got gynecomastia building up, and they've got all the signs telling us that estrogen is super high, this is where a small dose of AI can be used in order to bring the estrogen down fast. If you just modulate the stack and you're already getting all these side effects, it may take 7 up to 2 weeks for that androgen to estrogen ratio to actually level out. So you need to take that in consideration. The AIs, yes, they're bad, but can they be used? Yes, absolutely. In another instance, AIs can be used in peak week in some people that are more so prone towards holding a little bit of water even when the estrogen isn't that high. This is where you would actively want to lower the estrogen even more. And trust me, the people that say it doesn't make a difference, I can show you pictures of me pretty dry before the use of Arimidex and then implementing Arimidex and getting completely bone dry. So this is where I do not agree with people just throwing broad statements and claiming certain things with no context. Trust me, there's a lot more to drugs and what they do than what people actually see from clinical evidence, because there's so much more anecdotal evidence of people actually doing it and seeing things happen that necessarily on paper shouldn't. Now, estrogen, obviously we all know it's got neuroprotective properties, cardioprotective, renal protective properties. So maintaining a healthy amount of estrogen is not only going to support your bodily systems and keep a better lipid profile, but to a degree, I do believe that keeping your estrogen in check and in a decent position will actually in turn lead to more progress. So how do we manage estrogen levels? We simply manage it through our stat design. Take only as much testosterone as you can tolerate without needing IIs, and then we build up using DHTs, primobolan and masteron. Now, take into consideration that primobolan will lower estrogen much more than masteron. So if that is your drug of choice, your testosterone dose may need to escalate alongside of your primobolan escalating. Does that make sense? Hopefully it does. If there's any questions, we can kind of go over that as well. Now, compound use 101, the basic stat design layout from what we know from a lot of research and what we know in actual anecdotal evidence. Now, use as much testosterone as you can handle without estrogen side effects. Clinically, 2 milligram per kilogram is the clinical dose. So generally, if you go to a TRT doctor, they would take your body weight and they would calculate it on a milligram to kilogram basis. So the way it would work is myself, for example, 120 kilo times 2. It would mean for me, my TRT would land me at 240 milligrams per week. Because again, that's based on my body weight and the 2 milligram versus kilogram basis, which is always used in clinical research and in clinical use with TRT clinics. Now, in America, this goes completely out of the window because I have seen TRT clinics prescribe like 500 milligrams of test per week. That is not TRT. That is someone running a cycle. So let's just make that clear. Now, most of us can easily use between 200 milligrams up to 400 milligrams of testosterone without a DHT compound or an II in place. There are obviously outliers. Some people can take more, some people will need less. And I have worked with people who cannot literally tolerate 150 milligrams testosterone without the need of a DHT compound or an II. So the easiest way to determine of what someone can handle is doing 50 milligram increments on a weekly basis. So if you are working with a client who is looking to go on cycle, they've never used anything before in their life, and the cycle should be and will be testosterone only cycle, you would start them off at 250 milligrams if there was a heavier lad, 150 milligrams if there was a smaller lad. On a weekly basis, you would titrate that dose up by 50 milligrams to find the sweet spot that they can tolerate. Now, some things you may want to consider. The higher the body fat levels of any individuals, the more their dose of testosterone will aromatize. The leaner they are, the less aromatization will actually happen. Because believe it or not, there's actually estrogen receptors that do build up in fat cells. So in short, putting it in simple terms, the fatter that somebody is, the more estrogen they will convert. So that is also a massive consideration you do need to make when it comes to utilizing testosterone, especially when it comes to dosing the testosterone and understanding, obviously, how much they may be able to tolerate or not. And the toleration of the testosterone will also change depending on how much muscle mass, lean muscle mass they have versus body fat levels as well. Now, once they hit a threshold of the testosterone, this is where you add in drugs which do not aromatize. So your DHT compounds, which is going to be primobolan and masteron. Now, in order to raise androgens, that is definitely my go-to because they will not require any use of IIs. Nandrolone, on the other hand, again, it does aromatize a little bit more and it will potentially mixing it with testosterone potentially lead to much, much higher aromatization levels, which is not necessarily something we want with testosterone already at a place of where it is. Now, always run a baseline level of testosterone and only go up to a level you can tolerate. Then you introduce in Mastron and Primo or Proviron. And then you can also build up testosterone a little bit higher based off not only the androgen load requirements, but also based off someone's tolerance to the drugs as well. Now, one thing you should notice as well, the higher the DHT compound, the more testosterone someone will be able to handle because of the androgen to estrogen ratio that is getting skewed. So more androgens through DHT compounds, so more Mastron and Primo, higher testosterone can be added. Now, DHTs are key in stat design. They will aid sex drive and obviously improve androgen to estrogen ratio. Now, when it comes to oral use, and that's something I definitely do not want to miss out. Now I've got the basics out of the way with utilizing the basic compounds, your testosterone DHTs, which I do believe 90% of people, that is all they need. All you need is a healthy amount of testosterone and either Mastron or Primo or even a mixture of both for a very successful growth phase. Now, situation use for orals. Anavar is always going to be the safest, and out of all orals, if anyone is going to use any orals, Anavar would always be my go-to because one, it does not aromatize. Two, it does have amazing properties when it comes to performance and obviously production of collagen. So even your skin will look better utilizing it in some cases. And Anavar is definitely one of the compounds that is going to have the least damaging effect on your lipid profile and liver out of them all. So Anavar should always be the go-to when it comes to considerations for oral use. And again, if someone is at a very high competitive level, I will get into oral use a little bit later because there is other uses and purposes that we need when competing at a higher level. And again, there's a lot of educators that are of an opinion that orals don't really make a difference. And I absolutely disagree with this. Orals will make a huge difference to not only the visuals, but also performance in the gym. Especially when someone is lean. It does definitely make a huge difference. Now, 19-NORs, which is your nandrolones, trenbolone, they do play a role in stat design. However, the reason why I am not a fan of using nandrolone, one, it's a lot more neurotoxic. So the potential damage on your brain is going to be much, much higher. But the water retention that most people get and the anxiety that it will drive in most cases is not worth utilizing. So nandrolone, it can be used in specific individuals. However, in most cases, it's a compound I tend to stay away from because of the nature of the side effects it does bear. Now, what should we and shouldn't we use? Now, watching this presentation, guys, you can see a clear outline of what we should use, which is your basic testosterone and DHTs. This is your safest and most effective stat design with the ability to actually control your estrogen and hormones the easiest because you've got a clear guide from your blood work if you're unsure on managing your estrogen and even prolactin to a degree. You can simply get your blood work done and you will get clear answers. If you'll start messing with nandrolones, trenbolones, even boldenone to a degree, you will not get the same clear picture. So what should we use? We should use compounds that have been used and approved for human use over the past 20, 30, 40 years. This should always be the baseline and your go-tos. What shouldn't we use is compounds that have not been approved for human use, such as boldenone. And I have never been a fan of boldenone for the reason of the side effects it always had on hematocrit, which is definitely not something that you want, especially knowing that all PEDs will drive your red blood cell count much, much higher. Boldenone does this extremely well, and it's not something that we actually want. Now, secondly, nandrolone, I don't believe that is another compound most of us should be using at higher doses. Utilizing it in very small doses situationally can be good and can be beneficial. However, at higher doses, again, neurotoxicity bears alongside of anxiety that it can actually cause is not worth the trade-off when we actually use the compounds. Now, oral use, I do believe 99% of people should stay away from orals, especially if they're guys that are not looking to get on stage. I do not believe any oral use should be considered. However, if someone is adamant on a short stint, Anavar is always the best go-to. Now, why Primobolan? Obviously, we've gone over why I do believe it's so effective and the reasons why I like to use it for the properties it also has. Now, it is also a very low stress drug. It's very effective and most people will not feel any side effects. Now, another consideration people need to make is with Primobolan, you will almost not feel like you are taking any drugs. And I do believe the biggest issue we have with our culture at the moment, people often base the effectiveness of a drug on how much side effects they get. That is not a good thing. When you are using a cycle, you should not feel like you are on cycle apart from the visual changes you see and training performance. Other than that, you should not feel like you are on cycle. Now, suitable for female use, we've got studies with females using 1,000 up to 1,400 milligram of Primobolan per week. And it showed no adverse side effects apart from, obviously, virilization over time. So, as you can imagine, if females that weigh probably half of our body weight can get away with using 1,000 milligram per week with no adverse side effects, this kind of gives us a green light that potentially it's a drug that we can use at higher doses, much, much safer in comparison to nandrolones and in comparison to any other compounds like Bolina. It is approved for human use. It's still used to this day to treat anemia and in HIV patients as well. So it's still used to this day, guys. I can tell you one thing for now. Boldenone isn't used, not with humans anyway. Trenbolone isn't, and neither is nandrolone. Not that I know of. Lowers estrogen much, much more in most cases compared to Mastron and any other compound. So when we look at stat design, Primo makes a lot of sense alongside of testosterone to not only have a higher milligram total for people that need it, but also managing estrogen with no IIs through lowering that estrogen in people that may need that in place. Now, let's go over a little bit an overview of what I've gone over so far and more so the modern PED deployment in current use. So baseline, we should always start with testosterone and then we should creep our testosterone dose to as much as we can handle without excessive aromatization. Some aromatization is completely fine, but we do not want that to be excessive. Now, pairing your testosterone alongside of DHTs, Primobolan or Mastron to raise your total androgen levels. And again, the total milligram of androgens is going to be based off your needs. It's not based off any arbitrary numbers. It is more so based off your previous use, your size, your goals, and your risk versus reward ratio. Now, why testosterone? Testosterone should always be your baseline because, again, it's not only the most bioavailable hormone, but it's also a hormone that your body is most familiar with. Your body produces it on its own. So anyone who can use testosterone at a higher level, it's the best compound out of them all because it definitely does actually hold the least side effects, one of them being somaromatization, which is not a bad thing. So always be mindful of that. use of 19 NORs, nandrolones, and trenbolone. It can be utilized for more advanced athletes. I would only utilize nandrolone with athletes who know, can tolerate. And again, trial and error, guys. If you are working with more of an advanced athlete and they know they can handle nandrolone really well, this is where it might be an option for them. Also, another consideration is if you're working with a lot of guys overseas, is actually being able to get real compounds. They might not have access to primobolan or even mastron. This is where you've got no option but to use nandrolone to actually meet the total milligram needs. Trenbolone, again, can be utilized in very, very advanced athletes in very, very low doses. So look up the clinical doses and pair it with that, making sure that the athlete does not go above and beyond 200 milligrams per week for an extremely advanced athlete. Proviron, it can be used further to manage androgen to estrogen ratio. Proviron does not have any toxicity on the liver. However, Proviron is very unique in its properties. It can actually help with managing androgen to estrogen ratio in a different fashion in comparison to other drugs. So it can be a tool to further manage that. However, only utilize it in most cases where people need it, or utilize it to further get more synergy out of all your stack design that you are using. Now, if there were other clear guidelines, rule and considerations that we should all kind of consider, is obviously testosterone should always be used as the base. Nandrolone, for those that can tolerate, will aid a lot more fullness. And I've seen that firsthand. And this is mainly through driving a lot more water into the muscle and obviously subcutaneous, so under the skin. DHTs, much better for performance and obviously increased androgen levels as well as increased protein synthesis. So DHTs are always going to be my go-to. However, utilizing Primo or Mastron in comparison to Nandrolone, milligram for milligram, I do believe Nandrolone is a little bit stronger. And I do believe you're not going to get the same fullness or same water retention from your Primo or Mastron in comparison to Nandrolone. This is why a lot of people are such huge fans of using DECA or NPP for that reason. So again, it needs to be based on individuals. For leaner guys who tend to stay extremely lean and can tolerate DECA, it can be used. For guys who are more prone to water retention and getting fat, I would not even consider DECA in any shape, way, or form. Boldenone is completely out of the question because of the effect it has not only on your lipids, but also hematocrit. And in comparison to Primo and Mastron, I do believe it's actually a weaker steroid. It's just something that a lot of bodybuilders have used for many, many years, and they're still stuck in the way. So Boldenone, off the table, not approved for human use, and a terrible drug all in all. Now, the fun stuff and oral use. This is something that I have come across much more recently amongst people that have consults, people that always have questions, and seeing it in person, what it does and how it does it through years of competing. I've seen a massive difference utilizing these compounds specifically. So I want to go over 4 orals that I do believe should be considered out of them all. And again, there's more orals. There's funky ones such as Superdrug, which again, most people cannot get. So I don't think it's much more worth mentioning anyway. Now, oxymethylone, anadrol. In a peak week, believe it or not, I have used it with some guys who are extremely, extremely peeled during the carb up. And for driving fullness, it works extremely well. Now, I have also seen it used in combination with Winstrol, which is a little bit of a funky compound mix, which I definitely don't advise everyone to do. This is more so used at an extremely high level for driving performance, retaining fullness, and still seeing the visual improvements and management of water through utilizing Winstrol. Now, anybody who tells you you don't get a little bit drier through utilizing Winstrol, I don't think they've ever used real Winstrol. Anecdotally, I have seen massive shift in water and even some fullness and hardness to a degree utilizing Winstrol. So I do believe it does have its place when utilized in a peak week or even last stint of prep. So a combination of these oils can be used, or they can be used as standalone. I have used each of these compounds as standalone, and I know what they can actually offer in terms of the effects and side effects. So you've got anadrol. It will promote a lot more fullness. If you are still carrying body fat and water, you will also experience a little bit more water retention in those areas, as well as fullness intramuscularly. Now, halo testing. This is a huge one because halo, and again, real halo works incredibly well. Fullness and performance is extremely noticeable, even in dog end of prep. However, with halo testing, I have also seen anxiety, anger, and poor mood swings increase much more than any other compound I've ever seen. So if you know your client mentally is not going to be able to tolerate it, it's off the table. However, if they can, the fullness and performance benefits that it bears are huge. So it can be considered and it can be used situationally only. Winstrol, visual improvements, management of water. This is why I do believe it worked incredibly well paired with oxymethylone. But again, the side effects I've seen on lipids from utilizing Winstrol are huge. So again, risk versus reward ratio has to be considered when utilizing such compound. And I would only utilize it in the last stint of your contest prep. That is the best way to go when it comes to utilizing Winstrol. Again, situational use for a very short period of time. Anavar, my favorite oral of all time. The safest and most effective orals of them all. It's amazing for performance. It does aid in a lot more fullness, and you do tend to hold a lot more intracellular water. So your body does pull more water and carbohydrates into the actual muscle, utilizing them. Pretty much utilizing orals, but specifically Anavar. So this would always be my go-to in a contest prep for both males and females. Now, comparing Anavar and Primo in female use, I'm going to be very, very brutally honest. Primo will give you more, but it will also give you more side effects. Females, situational use, low dose of Anavar, 3 to 4 week stints, especially for girls who are in the lower classes, works incredibly well. Another consideration to make with Anavar, it's in and out pretty quick. Primo, the half-life of it, even though you're actually off cycle, you're not actually off until the drug is fully shifted out of your system. So as an overview, situational oral use only, there's only 4 orals I would consider that can have use and will work well in certain situations and certain individuals. So guys, any questions? I know there's a lot to take in. This is why obviously you'll have access to this spreadsheet as well for yourself, and you've got the guidelines to follow from there. Now, any questions or any specifics that you want me to cover, I'm more than happy to as well when it comes to any compound use, any compound mentioned in the presentation. All good? Right, if you do have any questions, let me know, and we can cover it anytime. So guys, thank you so much. I appreciate you all, and I'll see you again soon.